All right, genetics. This one is pretty short and straight to the point. There's two or three other YouTube videos that I'll put the links on that I think explain this stuff better than I can. But I did want to have at least a core here for you to look at. So the first thing I want to do is remind you that when I talk about reading assignments, remember the exams are not going to have a lot of minutiae that you had to memorize. The reading assignments are really there to sort of skim and really see, is there stuff that you would really find useful? Again, my philosophy is that you don't learn things until you learn them in context. So I'd rather have you learn something, look it up, read about it, learn a little bit more, look it up again. There's an abbreviation that I've actually recently come across. It's called too long, didn't read. And unfortunately, there's a lot of things out there that are so long that people just don't bother with them. A lot of us are used to sort of the Sesame Street generation where things were short, quick, to the point. I think there's a great appeal to that with what we're doing. So the chapter on genetics in the textbook has some really good stuff. It's probably got 10 times more than what you need to know at this point. So I would, as I say, I would skim it. Look at the general concepts, and then it's there to go back and look at if there are other things that you really do want to delve in a little bit more. So I'm really going to talk about four major topics here, and there'll be really other YouTube videos that will really explain them better than I can. But pharmacology, I think the cytochrome P450, and again, you'll learn more about that in your pharmacology course, but these enzymes, which people inherit from one another, are critical to how drugs are metabolized and other substances in the body are metabolized. And I think we're going to understand this better as the time goes on. I've been saying this now for about 10 years, and it really does seem to be coming to fruition. There's other things for genetics that are important, risk stratification, looking at specific cancer risks. Um, Again, I think that these are really hard to look at. These are probabilities. There's certain things like Lynch syndrome, those kinds of things that really do seem to increase the risk. But we'll talk about those specifically as the course goes on. There's certain genetic diseases. The ones that I see occasionally are I have a hemophilia patient, and there's more folks coming back with that. It's something you should at least be familiar with. Von Willebrands is way more common than I think any of us realize. The vast majority of people that have von Willebrands are undiagnosed until they go to have a baby and have a postpartum bleed, or until they have an accident and have a hemorrhage. Those folks probably should be figured out way more often than they are, and that's something I'd like to raise a little bit of consciousness about. Thallasemia is a not uncommon condition that we see. And again, whenever you have somebody with a microcytosis, once you've sort of ruled out iron deficiency anemia, this should be something that you're thinking about. Now, epigenetics is a frontier. For me, it's rather mind-blowing. Basically, it's really talking about how you've got that genetic code, but then laid on top of that genetic code is all of these factors that determine what genes are expressed and not expressed. And so there's methylation, there's all these different things, the chromatin. And the issue is that if we really can figure out why some genes are expressed and some are not, we're really going to be able to alter the course of many diseases. Epigenetics is kind of interesting because it does seem like these characteristics are actually passed down from generation to generation. You know, we always mocked Lamarck because he said that you could cut a rat's tail off and then the offspring wouldn't have a tail. That's really kind of been disproven. On the other hand, there does seem to be some evidence that if you have a dietary deprivation at the age of 10, it alters what's on the sperm, and that then is passed down to the offspring and even to subsequent generations. So environmental factors can alter your genes, and then those can be passed down. So this is, as I say, this is a frontier, this epigenetics thing. and I have a pretty good talk. It's actually a TED talk that I have a link on Blackboard on Canvas too. I'll get used to it probably 3/4 of the way through semester. So, we have at least 20 or 25,000 genes. They've got DNA in them. They've got RNA in them. There's a lot of things that determine whether those are expressed. There's certain infections that attack that RNA, HIV, for example. There's certain simple things that are either X or Y related, and so there's sex-linked characteristics and sex-linked diseases, and having multiple, having Klinefelters if you've got somebody with an XXY, and then those basic Mendelian traits and inheritance. So hopefully you learned all that stuff in your undergrad. If not, you'll have to sort of go back and brush up on it as you run across various diseases. So the cytochrome P450 system, there's lots of different types. There's 2A6, there's 3D4, there's dozens of different types. And as I say, there's a bunch of different YouTube videos. I've posted some, and then there's others that you can probably find yourself. One example is that codeine, the medication codeine, has to be transformed into morphine to be effective. As plain codeine, it does nothing. This is dependent on the cytochrome P450 enzyme 2D6. And so 2D6, if you happen to lack it, like 5 to 10% of the population do, you get no benefit from codeine. So this is why some people, you give them a Robitussin with codeine, and they're like, oh, this is terrific. It really took my cough away. It's fantastic. Other people, you give it to them, and they say, I don't know why you gave that to me. It didn't do anything. It was absolutely useless. It's also interesting because there's a lot of medications that will either inhibit or stimulate the function of a particular enzyme. And so if it stimulates the function, those medicines get used up more quickly. If it inhibits it, then it slows it down. And if it's a prodrug, like codeine, that has to be turned into morphine to work, it may not work. If it's a drug that the initial drug works, but then it metabolizes into an inactive form, the effectiveness will last longer. So it's a very complicated, interesting process that, again, you'll learn a lot more about in pharmacology, but it is definitely a genetic process that you should understand. So as I say, there's lots of risk stratification that happens with cholesterol levels, with hypertension. These are people that have something that's identified as a genetic disorder, and then they get counseling. So you have someone that has a melanoma. There's certain melanomas that tend to run in families. And the genetic counselors will go back and they'll do this diagram of all the different people that have been in the family, and they'll try to figure out where the issues are, and then they'll try to help people figure out what their risk is, and then whether or not there are any behavioral things that they can do to avoid it. Melanoma, for example, wear sunscreen, that kind of thing. Lynch syndrome is associated with colon cancer. We're going to have a discussion on the Blackboard about that one, and so we'll talk a little bit more there. Hemophilia, unfortunately, a lot of the folks with hemophilia needed factor VIII replacement. The problem is that they were getting much of this factor VIII replacement in the 1980s from prisons. A lot of the prisoners would donate blood. They'd get time off their sentence for doing this. They would then take all the factor VIII out of that blood, pool it all together, and then inject it into hemophiliacs. Well, the problem is that if you had 100 people donating, and even if 4 or 5 of them had HIV, then everybody that got that pool of factor VIII then developed HIV, and unfortunately at that time AIDS was pretty much of a fatal disease, and so a lot of those hemophiliacs died out. So we are seeing it come back. I have a couple of patients with hemophilia, but it is something that is very much of a genetically determined, and it is a sex-linked gene, and as I say, we'll kind of review that. Von Willebrands, as we say, is a blood disorder in which the blood doesn't clot properly. Therefore, these people have excessive bleeding. It does not usually become an issue unless there's a major injury or delivery, in the case of childbirth, that would cause bleeding. And so these folks really Yes. Sorry about that. A little bit of a cough there. So these folks have bleeding, and unless you know they have it, then you can't be ready to treat it appropriately. Thallasemia is an inherited disease, usually found in people of Mediterranean descent, and it's when the body doesn't make enough of the protein that goes into hemoglobin. And when there isn't enough hemoglobin, the red cells last shorter time, there's fewer of them, and they're much smaller. If you have a heterozygous person, they may have mild symptoms. Homozygous thalassemia is often fatal. Now, alpha-1 antitrypsin is a fascinating condition. Now, it is a disorder in which people who lack this enzyme will develop COPD very young. They can develop liver problems. There's lots of different things that they can get. Up until recently, there was no way to create alpha-1 and supplement it, and so therefore we didn't really even test for it. But now, especially in a younger woman, a woman in her early 50s that develops a COPD, we really should test, because if we do find an alpha-1 antitrypsin deficiency, we can actually supplement it now. It's over $100,000 a year for the treatment, but it really does improve the quality of life and the length of life for these folks. Because it's such an expensive medicine, most of the companies that make it will actually test people for free. So you can easily get online a kit to test yourself for alpha-1. Most of the people have to have genes that come from both one parent and then one from the other. And when you look at it, we do the testing, we do the genetic testing. Most people will have an MM pattern. So that's a normal from a mother, normal from a father. When you have somebody that's gotten, one M, one normal gene, and then one abnormal gene, they have an increased risk of having disorders associated with smoking. But it's much milder than someone that has homozygous for the bad genes. So someone that's a ZZ, that's really bad. Someone that's an MZ, much less bad. They do have a reduced amount of alpha-1, but they usually don't have major symptoms. But again, if you get two people with an MZ together and they pass down the two Zs to the child, that person will be at risk for their life. Again, SS is another possibility, MS, and so there's a bunch of different factors that may combine, and you'll see that depending on the types of genes that the person's gotten, they may develop various levels of the disease. And then epigenetics. Epigenetics is something that I think is absolutely fascinating. And these are factors that express the gene expression without actually changing the gene itself. So they change the methylation, they change the way it's wrapped, they change the layer that's right on top of that genetic factor. So they change the physical structure of the DNA, but not really the genes themselves. So they change the methylation, they change the way the genes are expressed. Histone is critical as well. Histone is basically what the genes are wrapped around inside the cells. If the histones are changed, it will change the way that the DNA is expressed. and people will develop certain diseases. So that pretty much covers what we're going to talk about for genetics. For next week, for the following week, we're going to talk about some immunology issues. And so Benny Schlemy is 6 months old. He's due for a well child check. And immunizations, what are they? How do they work? And are there varying different types of immunizations? So we'll talk about that on the canvas. And then 80-year-old woman cuts herself on a piece of rusty metal. She's never had a tetanus shot, she doesn't think. Is that possible? What do you do? Is there something we can give that will give her short-term benefit? Or should we just give her a tetanus shot? Or what should we do? And then Mary was found playing with a bat. She's got several scratches on her hand. Looks like the bit may have bitten or clawed her. What should we do? Should we give her some type of short-term medicine, long-term medicine, immunizations? We'll talk about that on the blackboard. I'm sorry, on the canvas. All right, that concludes the genetic slides, and immunology will be the following week.